Welcome to the second installment of the NYOH Breast Cancer Survivorship Series. We had a successful program last month. It's available on YouTube for any of you that missed it and want to tune in on it. I think we have a really exciting 1 hour ahead of us tonight with an incredible panel. Remember that this is by patients, for patients, and for all of us to learn from our patients so we can become better at what we're doing for all of you and for us. I would like to introduce our panel tonight. I'm going to start with my co-moderator. And for those of you who are tuning in for the first time, I am Maria Theodoulou. I'm a breast medical oncologist. I am the program director of the breast medicine service at New York Oncology, Hematology, spent 3 decades at Memorial Sloan-Kettering and needed something to keep me busy in retirement. So here I am working 7 days a week, 24 hours a day. And I am pleased to introduce my co-moderator, Arsyl de Jesus. Dr. de Jesus is a radiation oncologist. She is on the board of New York Oncology, Hematology, and the vice president. And she is just a joy to work with. Well, I'm going to go around the room the way I see the room. And the next introduction is going to be Dr. Bridget Finn. Wave, Bridget.
Hello.
And Dr. Finn is going to keep this program lively tonight. She is the founder and the president of the Capital Region Center for Sexual Health. Need I say more? I think I'm going to do a one-to-one just with Dr. Finn and myself. So we will be able to broach subjects that we think about, we wonder about, and sometimes just don't have it in us to talk about or someone to talk about it to. Going around the clock, there's Stacy Fischer-Rosenthal. Wave.
Good evening.
Stacy is really the reason why we are all here and why we've been here through the years with the COVID interruption. Unfortunately, she has been the benefactress of our program. She has been tireless in not only advocating for patients since her own breast cancer diagnosis. She's the president of Fisher Travel. She's going to tell you more about it. And I've known her for about 22 years now. Yeah, there we go. And we'll hear her story shortly. And going around the clock, we've got Dr. Monique James. And I am so pleased to have Dr. James here. She is one of the attending physicians on the psychiatry service at Memorial Sloan-Kettering Cancer Center, Psychiatry and Behavioral Sciences. She is really dedicated to dealing with women, how to develop tools, how to develop how they wake up tomorrow morning, and how to deal with those words, breast cancer. And we're going to hear a lot more from Dr. James. And ending the panel, but never ending the day or the hour, is Colleen Murray, who is an advanced practice provider. She's a nurse practitioner on the breast medicine service. I'm glad that she's my nurse practitioner. I couldn't run the service, the program, or my daily life without her. She's an incredible woman, and she's going to tell you her story because she just started on the breast service just about 2 years ago, learning what breast cancer was all about. And I would like to say it was from me, that I was her mentor and her teacher, but no, it was through her own diagnosis of breast cancer, just at the time when she was going to start working with me. So we have an incredible program. I'm going to share a screen just for a moment, and so bear with me. I hope you'll all be able to see it. Please focus on the picture on the left. You will see a family of 3. That's Stacy Fischer-Rosenthal there with her hand on her son's chest, her husband, her son Max, and Stacy. When Stacy got her diagnosis of breast cancer, and I told her that she would lose her hair, we're going back 22 years ago, everyone shaved their head, and this picture made national news, and it just gives you an idea about how she approached her diagnosis and her story. On the right is Colleen. And this is 2 years after her breast cancer diagnosis, just a couple of weeks ago, who qualified for the World world champion Ironman, and that gives you a little bit of a feel of who we're going to be talking to tonight. So I'm going to start this off with a word, and it's something that Colleen and I debate an awful lot, and it's the word survivor. Is it a positive context? Is it a negative context? How do we feel about that word? Should we find another word for what we think it means, and what does it mean to everyone here? So Colleen, let me have your thoughts. If you could tell us a little bit about your story, and then tell us what your thoughts are about the word survivor, which you and I debate quite a bit.
So my story is interesting. I have been a nurse practitioner for 21 years, and I originally worked with NYOH about 15 years ago or so, and then I stayed home and raised my children. And then I decided I wanted to come back to work at New York Oncology because I love them so much. So I had been going for a screening mammogram in January and an ultrasound, and it was my very first day starting at NYOH. And I got a call that my mammogram was abnormal, ultrasound was abnormal, needed to go for a biopsy. So this was literally my very first day as a nurse practitioner at NYOH working with breast cancer patients. So, fast forward, biopsy positive, breast cancer diagnosis, and I'm working with Maria now in the office, seeing patients that have breast cancer every day. And it was an interesting feeling of now being diagnosed with breast cancer, not knowing my own mortality or what was going to happen, and trying to encourage patients that, they were going to be okay. So Marie and I always have this conversation about survivorship and what is a survivor. And, it's interesting with breast cancer because sometimes some of those words to me don't always sound positive, a survivor, a warrior, a battle. So I don't know how I really feel about those words, and whether it's because I choose to live and I don't choose to battle, or to me, they don't seem as positive as sometimes as I wish they would be, because I want to tell our patients that they should live life and they should enjoy things. And that's why when Maria showed the picture of me doing Ironman, that's part of my story. I've chose to live. I've chose to fight. I've chose to, enjoy every day. And that's what I want for our patients.
Well, there you go. And you did use the word fight. And if we were to look at the root of the word survivor, look at the actual root, it comes from the Italian, the Latin, vivere. And vivere means to live. And, we have all sorts of definitions. If we would go on Google and pull up a definition, one of the ones that I pulled up before the program, a person regarded as resilient or courageous enough to be able to overcome hardship. Well, I will tell you what my bias is. I think a survivor is also that patient who is courageous and maybe can't overcome their hardship. And they're survivors too, in the best sense of the word, because they are writing the chapters of their book. And it's how we write our chapters and how we read those chapters at the end of day, end of life. We only have, what does the New York Times say? 4,000 weeks of life from the time we're born until the time we exit. And those weeks go by quickly. So vivere is to live. Stacy, how do you feel about that? Tell us a little bit about your story.
So I am a 20-year-old survivor, and I do use the word survivor because to me it means strength. And I got myself through this, and it was a fight and it was a battle, but I was so supported and so lucky along the way to have a doctor like Dr. Theodoulou who put me on clinical trials. I was 39 years old when I was diagnosed with breast cancer, and I had lost my mother 10 years prior to that to pancreatic cancer. So I had only seen that view of cancer. And really, really scary time. And I started off with a lumpectomy, and it wound up being much more invasive. So it wound up I chose a double mastectomy, which I will never look back and think I did the wrong thing. I had chemotherapy and radiation. And, it's a journey. It's the start of a journey, a new journey, and a journey that enabled me to realize and appreciate really what life is all about. And like you said, it's about living, Colleen, and it's about choosing that path. And that photo was my husband and son came home from a Met game and they had shaved their heads and they took off their baseball caps. And I just sat and cried. And then after my chemotherapy, I remember saying, I want to give back to all the doctors and my friends and my family and my colleagues that were there for me. And I had an It's Over party. And that was the invitation. It was come celebrate with the Rosenwalds. And my name is Rosenthal. And just like celebrate life and just continue that process. And in 2019, I had to have an exchange because my implants were recalled. And, you know, shouldn't have been a big deal, but for me, it wasn't an easy situation. I actually had 3 hospital stays, infections, a hematoma, and wound up losing a breast on my radiated side because my skin couldn't hold it. So also then thinking about, oh my God, I'm 19 years away and why is this coming back now? And how am I going to view myself now as a female and move forward? And I really thought I had to mourn my breast. And it wound up that I really just had to move forward and appreciate my life and that I have a life and I have an incredible husband who loves me for who I am and not for my breast. And do I have breast envy? Of course I do. Do I look at, you know, magazines and say, oh, I wish I could wear that, or look at how great and sexy she looks? It just doesn't define me. I'm so much more than that.
Yeah, for sure.
Monique, Dr. James, Monique, you deal with these cases on a day-to-day basis. You deal with patients who have underlying psychosocial issues that are exacerbated at diagnosis. You deal with women who have never had a day of depression or anxiety and now are encountering not only their diagnosis, their potential treatments, their potential mortality, but a new psychological world that is so foreign to them. How does one move through that? How do we get from the words, whatever our name is, to the words breast cancer and figure out a way when they're on the same piece of paper, how to separate them to get on with an empowered life?
Such a huge question, but such an important one. And I also just want to thank you again for having me as part of the breast cancer survivorship series over the summer. So sometimes I talk about how just like there's physical phases to recovery, there's also psychological phases to all of this. So to diagnosis, to treatment, and to recovery. Diagnosis, treatment, side effects, complications, unexpected things, and also recovery. And so what happens really quite frequently, and which is actually quite normal, quite typical, normal, typical, common, appropriate, understandable, right? All of those words, is that women get diagnosed with breast cancer and there is a shock. And whether it is that you've had a family unit full of women and or men who have had breast cancer before, or whether you're the only one. Whether you're 28 or whether you're 88. A lot of times there is this kind of initial period that's, did that just happen? Did I just hear those words? Oh my goodness, here we go, right? And after that, a lot of women very typically put their heads down, start to check boxes off, which means, how many appointments do I have to go to? Do I need to do fertility preservation? Do I need to get ready for different kinds of chemotherapies, of surgeries, of radiation, depending on the kind of breast cancer that I have? Even to back up before that, how can I understand the breast cancer that I have, right? So there's all these kinds of check boxes. Do I need to take care of my business? Do I need to take care of my family? Do I need to take older or younger? So they tend to go into this kind of checkbox mode, right? To-do list mode. And this is very, very normal, very common. And so what we see is that, yes, I definitely get referrals around diagnosis and treatment period, especially for psychiatric side effects of the treatment. But a lot of the referrals will actually come at the end of surgery, at the end of chemotherapy, at the end of radiation, because it's also very normal to not, now you're not having to go to the clinic 3 times a week, 5 times a week. Maybe it's reduced down to once or twice a week. And you now have this space, both in physical space, mental space, emotional space. And we do see some of the kind of adjustment come up. So with that, we can have a range of emotions, a range of thoughts. Sometimes it's fear, sometimes it's relief, sometimes it's sadness, sometimes it's disdain, it's anger, the whole gamut. And so a lot of times, people will have these kinds of initial range of emotions, heightened emotions and shock in the beginning, a kind of like to-do list period during treatment, and then this kind of roller coaster. And now, obviously, that's not for everyone, but often that happens. And so with each phase, there's different kinds of tools that we need to use, different kinds of treatments that we can use. But I think the biggest thing is to reach out. The other biggest thing is that there's so much uncertainty and so much unpredictability in cancer. Diagnosis, treatment, outcomes, that anything that we can do where you have a choice is really important. Even this word survivor, should I use it, should I not, right? I have a pink ribbon here. I keep one on my white coat as well. I wear it actually in life outside of the hospital as well, because it's something that is very dear to me. For other people, it's not, right? And that's fine, because the main thing about this is, how can we make this experience unique? How can we make it ours? And how can we give some kind of choice in it?
I think the empowerment in what you're saying is really the ability to reach out. And I've, for a long time, lectured and taught fellows and residents, and, the mortality of breast cancer has decreased. We've gotten so much better at understanding the multiple diseases under this umbrella called breast cancer. Patients are living longer. Even with advanced disease, they're living longer. And most patients that are diagnosed with breast cancer will never develop metastases. Yet, we don't have that crystal ball of certainty. And there are 3,800,000 patients living as quote unquote survivors of breast cancer in the United States today, 3,800,000. And some of those are going to be successful and some of them are going to be unsuccessful. And I truly believe that a lot of it has to do with who we were, what we had available to us, what our choices were before we received the breast cancer diagnosis, what our concepts of femininity is, our sexuality. And I know, Bridget, Dr. Finn, you deal with this so very much. You deal with the concept of femininity, you deal with the concept of sexuality under a sexual health banner. And I know that I have referred patients to you successfully. I'm so glad you're up in the Capital District. I wish Dr. James was. But talk to us about these concepts, about these definitions of femininity, how they transport themselves across individual patients within the patient population, and how important is it to get that conversation going?
Yeah, so much of the work that I do with clients is really cultural therapy, right? It's really about, what are you being sold from society regarding what it means to be sexy, attractive, feminine, a woman, and what are you buying, right? So we do need to look at the broader cultural message, and we really need to challenge that. When clients come to me, it's really about, first of all, it's super awesome because they're coming to apprehend and claim pleasure and joy and life. And there needs to be a recalibration of sort of mind, body, spirit. And if the person's in a relationship, we need to look at the relationship dynamics that have occurred. One thing to keep in mind is, I have not met in my 35 plus years of doing this work a whole lot of women. In fact, I think I could probably count on one hand who say they like their body. We have an epidemic of women who do not like their body. And
irrespective of breast cancer.
That's right, irrespective of breast cancer. And so we have that hurdle, right? We also have the feeling of what's going to happen to my partner if I can't meet his or their needs, correct? So there's a whole fear of what does this mean for my relationship? What does this mean for how I see myself? What does this mean for pain-free intimacy and sexual pleasure? And is that possible? So the work with the women is really around them creating a new narrative around what it is now. And because this happened doesn't necessarily mean we have people who have had wonderful intimacy and great sex, and then suddenly they're not. So we also have a situation where some people are saying, I'm trying to get back to something that was really good. Or, you know what, I never really felt connected to my sexuality, and this has made me realize that I need to really look into that and take that journey. Then we have single folks who are thinking, when am I going to have this conversation about my body? And it's always about remembering that people need to earn your vulnerability. People need to earn that story. Right. And so we don't tell that story when we have our clothes off. We tell that story when we're feeling strong and grounded. Right. So we have single folks, we have people in relationships, we have people who want to get into relationships. So it really depends. But for a lot of people coming into it, it's sort of this made me realize that my sexuality wasn't really where I wanted it to be anyway. Don't know what's possible. Right. But we help her with that story of really challenging what is possible and challenging those broader narratives about what it means to be sexy and attractive and desired. Right. Desired. So a woman's sexual desire is intimately woven into feeling desired. And if she's doubting that because of this journey, then we have some work to do there. But a lot of cultural therapy goes on around any sex therapy, in terms of what's out there that you're still buying into. Let's broaden our idea. This is about expanding and increasing our story, our narrative, our capacity for pleasure, our variety of behaviors, our idea of what's possible. So it's really about advancement and expansion when the tendency is to kind of shrink away.
It's interesting that one of the things that you said was the worry about whether we are meeting the needs of our partner, whether that partner is male, female, married, otherwise. And I often wonder, how do we define those needs? Were we really in sync with our partner's needs prior to our diagnosis? What are we finding out about them? And how is that propelling us forward? And, there's clearly the intervention sometimes has to be with couples, not just the patient alone. And sometimes I wonder if we haven't fallen short, even with a series like this, which I'm really proud of, if we haven't fallen short because we're not addressing some of the partners in these live situations and allowing them to voice their concerns. Am I going to touch her and hurt her? If I touch her, will she shrink away from me? How can I tell her that I love her? Or maybe I'm having trouble looking at this new person in my life. How do I recalibrate my own vision? And I truly think we have to have a program in a few months with some of the partners and their issues. And then Bridget and Monique, I will be calling you back in.
Yes.
It's such an important issue. And when, the issue of breast envy that Stacy brought, that's such a a potent term. It really carries so much weight. And there's no question it's what's going on within that space that we take up. But there's also, I find, in women who are mothers, in some of my patients, and we get to talk about this behind closed doors, the feeling of guilt that they may have that they're passing on a worry to a child, male or female, whether it's now they have to worry about breast cancer or they have to worry about me. And how do we make our children go through this, at least initial journey, feeling empowered and not having to worry? And clearly both Colleen and Stacy have been down that road. I've had young patients come to me and say, I can't lose my hair. I can't let my child see me without hair. And I went to the drawer, I took a pair of scissors and I have your child cut your hair. Put a big sheet on the kitchen table and find jokes to tell while you're doing that. Simple. Obviously, that would not work for everyone. It did work for this woman successfully. So how do we deal with our children? And this is a question for everyone. Arsyl, as a practitioner who has your own children and you meet patients on every stage level, encounter them, does that transfer back to you? Do you worry? Colleen, do you think about your daughter and your son? Or do you want to just give them the best face you can to give them that courage and empowerment? Stacy, Max has gone through it with you, and I know Max now, and a finer hunk of a guy you will never, ever encounter. He's just an incredible man with great sensibilities. Clearly, all of this impacted. So I'm going to back away and let you guys take this conversation. Arsyl, I'm going to let you go to Colleen to Monique, Stacy, and then back to Bridget.
Thanks, Maria. I think one of the things that I frequently hear from my younger patients is how young is too young, in terms of the children and telling them the truth and how much to tell them or how to tell them. And I myself will struggle with that, but I have known, having had cancer in multiple family members, I have found that children are very resilient, and if you try to speak to them not in baby words but as an adult in the simplest terms, they're better off with the truth than not. And as you said, to engage them in the process. But I think I would like to touch on what Dr. James thinks in terms of how young is too young, and if in those cases where we know, and this is obviously not for the two amazing survivors, and I would like to call you thrivers because you are more than that. So I that's my word for you guys, thrivers. You just don't live, you thrive, because you make something great out of this speed bump in your life. So in any case, I have had to go through some of my younger patients and their eventual demise struggle with how to help their children moving forward. But even in the simplest terms, how much do you tell them, and when can you start, and who should help you? What should I pull in? What kind of resources should I pull in to help them?
So there's definitely some best practices here, even though I will say it every family unit, you kind of know what works for your family and what doesn't, right? And we're not here to necessarily change the whole dynamic of your family, especially as it's going through a challenge, but there are some best practices. So one is that there's never too young of an age, but that you do have to use, just like you said, age appropriate language. So for some kids, it's going to be, mommy has a boo-boo on her breast, and that's sufficient. Other kids, you might use the word cancer, and that's fine. And other kids, you might use a different kind of word. But the best practice is always to say something. And another best practice too is that you never want your kids to have questions that they feel that you can't answer or that they haven't gotten answered. So you don't want them to go to the internet. You don't want them to go to the mailman. You want them to go to a trusted person. Hopefully it's their guardians, their parents. Sometimes it's not their guardians. Sometimes it's an aunt, sometimes it's an uncle, sometimes it's a teacher, but the person has to be trusted. And obviously you hope that that space is also safe for them. But one of the most difficult things is when a kid who you all have seen, whether you have kids or not, how observant kids are, right? Kids will know. They will know that someone is sick in the house. And so you never want them to feel that they don't have answers to how sick they are. You never want them to have magical thinking about the reasons why that they're sick now. Is it something they ate? Is it because we went to Florida last year? Is it because of, they went to the hospital? Whatever questions it is. So two best practices: talk in age-appropriate language. Never want them to have questions. Always want to have someone that they can go to. And actually, I think the third best practice, just as you said, Dr. Theodoulou, is we get them involved in some kind of way. It might not be in cutting off your hair, but it might be something like putting together memory books. It might be something like pictures. It might be something like baking something for mom to eat, or, depending on how old they are. And so giving them a task, and this is, true for kids and just loved ones as well, right? People want to be involved and they want to help. Sometimes they don't know how. And so sometimes doling out some tasks, especially to the kids, is helpful.
Stacy, how did you engage your son? I know you were much younger at that, during your cancer journey. How did you, have him part of your journey?
Sure. So Max was 7 and I was going through chemotherapy, and I remember someone coming to me. I was at Memorial Sloan-Kettering, and the social worker there said, "Why don't you come in and be part of our support group?" Which I had once taken my mother to a support group, and it was very depressing. So I wasn't quite sure if that was going to be right for me. And I went in there, with all these notions of negativity, and I wound up meeting people that I'm still friends with today. So I think it was really surrounding myself with people, and knowledge is power, and really listening to people who have spoken to other patients about how to tell their children, whether it be a book or whatever that was. And I'll never forget exactly where my husband and I were. And in fact, I was just out to the same diner in New York City. It's like a luncheonette with my son and his girlfriend. And I said, "Do you remember when I told you?" And he said, "No, I have no idea." So, the things that were so important to me, that I had to protect them, how to protect him. A year after my diagnosis, he had told me that a friend of his mom told him that I was really seriously ill and was probably going to die. So these things that they hold on to as well, that, I was like, well, why didn't you say something to us? And then you feel guilty because did we not give him that space to allow him to speak about that? Long story short, Max is now 27 years old, and he actually met his 7-year long-term girlfriend at a breast cancer event in college. So breast cancer has followed with him, and it was something that he chose to go to on an evening to support breast cancer because of his mother. And I think it's part of our life. And having gone through, this battle a couple of years ago, he was there for me. He is incredibly loving, and we're an incredibly supportive family. And I think we've really allowed ourselves to be open with him, and also gave him the ability to speak to somebody else, because it was the year of 9/11. It was the year my father-in-law died. It was the year I was going through breast cancer. And it was the year a friend of ours' house burned down. So there was a lot of trauma. And we didn't know what the right things were in the tools. So we had him speak to a therapist, and then someone who was geared towards children. And then he came home one day and said, "I'd rather speak to you." And that was okay, but at least we were able to give him that space.
Well, every household has their own story, and it really is based on the dynamics that evolve over the years from the time the child comes home with us from the hospital or born in the house, and how we interact and what our communication skills are. I'm going to tell you a brief story. It'll take about 60 seconds that I've never told publicly before. This will be the first time. And I had gotten into medical school, and I needed to have a physical exam. And my daughter was about 7.5 years old, almost 8, and they found a lump in my breast. And I was sent to the chief of breast surgery at Memorial Sloan-Kettering Cancer Center. So I'm telling a story that goes back almost 40 years. Back then, you were admitted the night before, and you had to sign a piece of paper that said if the path, which was done at the moment, they looked under the microscope, was positive, that you would lose your breast. And you had to sit through a film in a room full of women of all ages talking about what a mastectomy was. And before I went to the hospital, I needed to talk to my daughter because I was a single parent and I was in my very early 30s. And I said to her, mommy has to go to the hospital, and they might find something in her breast and they may have to take the breast off, honey. And I was dreading the words. Each word seemed like it took a minute to get to the next word, And she looked up at me and she said, I was 104 pounds then. And she said, Mommy, nobody will notice. And she bounced off into the other room. And I was like, wow, nobody will notice, because it really didn't mean that much to her, and I wasn't defined by a breast to my daughter. Ultimately, I had a tumor that was benign. I found out very early in my career that I was terrified of breast cancer, and the only way that I would confront it is by devoting my career to it. And I have to say that interaction with my daughter, who will never remember it, really was a springboard for me as what goes on in us may be less important or more important in a different way. We just have to not get paralyzed within the place that we are, so we can really open up our arms and bring it all in. Am I making sense to you guys? Yeah.
Yes.
Colleen, you were dealing with 2 kids,
Yeah.
a boy and a girl, and at informative stages of their not only body image but their sexuality.
Yeah, so thank you. So my children so this was 2 years ago, 2019. So I was 44 at the time of my diagnosis, premenopausal. My kids were teenagers. My youngest daughter, she was 11. My son was 14. And so they obviously knew my job was in oncology, and I took care of patients who had cancer every single day. So they were used to the words cancer, right? They knew I'd come home, I would talk about my patients. They understood it, but they also were slightly scared by it because they also knew that some of my patients had passed and didn't quite understand. They were teenagers. They didn't really quite understand what was going to happen to me. So explaining to them, now that I knew that I had cancer, I was afraid that they were going to be terrified that something terrible was going to happen to me. But it was quite the opposite, actually. Like Maria said with her daughter, how she sort of bounced off. They were strong. They were my strength. Even to this day, my daughter made this picture and she put it in my room, and it said, you are stronger than you think. And she framed it. And it's like this little person that she drew, and she set it on my nightstand because she knew I'd be like resting in my bed. And my kids were amazing. They were resilient. They never missed a beat. They knew that I was tired, and they knew that I needed a rest, and they weren't scared. They knew that I was going to be okay. However, to touch back on Maria's original thought was, how do I feel about it? And do I feel guilty now that I have cancer? And could I make their lives more at risk because of that. So I am genetically positive, and now I have a son and a daughter who I do have to worry about, and I do need to make sure that they get their screenings and their health care. But again, I view that as a gift, a gift that I can give them. I know that I'm genetically positive. I know that I can be proactive in terms of their health care. For my daughter, I'll be sure that she gets screenings. For my son, I'll be sure he gets his screenings. And, you know, we talk about this all the time, that even though now that they're teenagers, they're 17 and 14, they need to, you know, do their breast exams, and it's okay to touch their body, and it's okay to feel themselves in the shower to know if something feels different. And even though it seems weird at 17 and 14 to have this discussion with them, I think it's important. I think they need to know that I was 44 and diagnosed, and they could have a genetic predisposition, and we need to make sure that they're safe. So again, I sort of try to view it on the positive, like, you know, this is a gift for us. Like, I was diagnosed and I'm great. And now I know that there's a gene and you are going to be great. So I think, you know, I view it as a positive for my kids.
You know, the theme going round and round is communication and having the discussion, and not putting it into a closet, bringing it out into the open in the language that's understood for that particular age group, including when we have to deal with our parents who may be older and came from a generation where you didn't say the cancer word. And, you know, as someone who has specialized in breast cancer all of my career, I have done many hundreds of consultations on patients from Europe, from South America, from my own home country, Cyprus, where I will say to you that I've had patients come into me with advanced disease, and the family members have threatened me and said, do not use the word cancer. I have women who have been diagnosed who will not tell their daughters, will not get genetically tested. And I remember in my waiting room at Sloan-Kettering, it was a very busy day, and I had a patient who was just complaining about having to wait to see me, and she just hated the whole environment, and she never wanted to come back to this cancer center. And my 84-year-old thriver was sitting next to her, and she turned around to her and she said, "Oh, just stop it." She said, "Thank God we're talking about it. We're here, we're sharing our stories, and we're letting women get to where they have to get to a lot earlier, because if the mortality has gone down, it's not because of what I do. It's not what Arsyl does with radiation. It's not what our surgeons do. It's the conversation that we're having and empowering the next generation to be better than us in being proactive." And Bridget, I'm gonna throw this to you. And you know, there's a life paralysis that occurs in some of our patients who may not have the right tools. And it's not just a sexual paralysis that we have to deal with. It's a general life paralysis. And when everything seems to stop, everything has stopped, and one foot can't move past the other foot to move forward. How do we help someone through that? How do we help them get out of that room they're in and find a place of light, or surfing a screen, or cooking a new recipe, or getting a graduate degree? How do we get past that paralysis?
I think we honor it first. We honor it, and we allow for their process. We identify who their support system is. We talk about refiguring what's possible for them in all parts of their lives, right? But the first thing is permission to be, permission to rest, permission to sit in whatever it is you're sitting in, with also the encouragement that this isn't the end of the story, and that possibilities are there, and how would they like to tell that story moving forward. But we never want to make someone feel bad about that paralysis. We need to honor it. We need to let them be in that a bit. And you know, what's coming up for me around everything we just talked about, the energy is so positive. So content is one thing in terms of words we use and what we say, but the energy that we show up with is so powerful. And the way, Colleen, you just spoke about your children and the energy around that, and Stacy, and empowering. And we don't want to anesthetize our children. We want to give them the idea that a full range of emotions has permission to be felt and talked about. And it's also a disease that hits directly on a breast. And for many families, the word breast was never used. So now we're talking about a part of the body that kids kind of know is tee hee hee ha ha ha, but right, so now we're challenged with that. And I work with a lot of folks who come in and say, how do I talk to my kids about sex? Right. So it's always about honoring where someone's at, allowing a ton of permission for them to find their own way, create their own story, and expand their idea of what's possible for them.
I read an article recently, which really caused me to catch my breath with the improvement in mortality, with the advancements in our treatments, and women truly more so surviving than not and well. And I use the word surviving in living more years, living without recurrence, truly surviving. There's almost been a bit of anesthesia, to use your word, with surrounding family members and friends, where the diagnosis is minimized. Don't be upset, it's only breast cancer. And that patient needs that time to rest and pay attention, as you say. And I personally am seeing a lot more of that with, maybe that's the way the family members and friends are protecting themselves, Monique, because we're dealing with, not just the patient, everyone else, but I'm hearing it more and more. Well, it could have been worse. It's only breast cancer. Wow. How do we help that patient not be minimized?
I think it's so true, right? Often the same way that we were kind of talking about what happens in our own kind of bubble sometimes is different with other people. For better, for worse, a lot of times the reaction for our loved ones, or even just people in our life, acquaintances and so forth, have so much more to do with their fears, with their known histories or lack thereof of cancer, with their concerns than it does with us. And in some ways, that can be hard actually for the person, usually the woman going through. But a few things kind of help. The first thing is that I just want to reiterate and shout to the mountaintops that every emotion is normal and healthy, right? A healthy brain is going to have a range of emotions, from disdain and resentment and anger and fear to happiness and relief and comfort, right? I usually use the words traditionally negative and traditionally positive because I actually don't feel like there's a negative and a positive emotion. All emotions happen in a healthy brain. The other thing is that an emotion like being upset about this, being sad about this, being angry about this, these emotions that are traditionally more difficult for people to see and to experience, they're all a communication, they're a signal. Usually they're a signal of some need that's unmet, or to just use a kind of broad term, or some other kind of signal. So, often I have people to kind of stop in that emotion. I love how Dr. Finn said to honor that. And I usually say that word as well. Honor not only that you have a functioning brain that's producing that, but that it's a communication. Your brain is trying to tell you something. And so we have to just kind of figure out what it's trying to tell. So sometimes I tell caregivers that, I tell loved ones that, right? That all of these emotions that you're seeing in the person who has the cancer, that they're signals. They're a way that we can learn a little bit more about what that person needs. As far as the minimizing, I think that really does happen. And in some ways, the root of it is really, it's not malevolence, right? The root of it is excitement that people are living longer and they're not having recurrences, or if they are, they're still being able to be treated. So I think one thing is to recognize that. But I often tell caregivers as well and loved ones to listen some more, right? And to try to meet the loved one where they're at. And if you don't have the right words, that's okay. It's fine to do a touch, do a hug, right? So I tell them nonverbal cues and support, just as important, sometimes even more important than words. So you don't have to, say the right thing if you don't know what it is to say. But I will say that that's probably some of the hardest conversations that I have with patients and their loved ones, is about how the patient's experience is not really being seen. Usually it is, from fear of the loved ones.
Dr. James, that's I love how Dr. Finn had relayed permission. I love that word, to honor and to permit to feel that way, and to communicate about all that emotion. I think there's a certain level of more complexity of cancer when it comes to it being in a woman, because a woman is also mother and wife. Not that it's not on the other hand, but I think we have just so many tasks that we need to do. And what my patients have relayed to me is that between diagnosis and the end of treatment, and all those hundreds of appointments, they don't get to feel, because they're just ticking off the task and making sure that they're here where they need to be, and they're taking care of the kids and their husband and this. And they have relayed that it is actually after that last chemo and or that last radiation, where they're not going to be in the office frequently, where there's suddenly all the emotions flow in, like they were not given a chance to grieve, not because they were not allowed to, but just their mind had to focus on the task at hand. And so I guess my question would be, first off, for Stacy and Colleen, was that your experience as well? And how did you deal with it? And for Dr. James, how should we help as their providers, knowing that that is likely going to happen? And since we don't want that to be a bad situation, I have had patients that have gone into deep depression right after treatment, like some kind of separation anxiety. And so that's why we're doing stuff like this. Survivorship is important, because there is life after all of that. So I mean, Stacy and Colleen first, sorry.
I think for me, I was just on this fight mode to just get from, diagnosis all the way through to chemo radiation, and was exhausted by the end of it. I remember just showing the happy face, and I'm going to do this, and I'm going to go to chemo, and I'm going to be at work, and I'm going to go to radiation every day, and I'm going to be at work. And I did. And then all of a sudden you hit the wall. So I think the word permission, and having families just kind of giving you that permission to say, we've got your back, it's okay. And I think also we have to be strong enough to say, like in 2019, when I was in hospital and all these different things were going on with me, I had a team around me that worked for me that said, you need to be where you need to be, and we've got your back. And having that peace of mind of having people support you on every level, personal, professionally, is incredibly valuable.
Yeah, and Arsyl, for me, I'm a much more check the boxes type person, where, I counted the days and I was like, okay, great, now I'm done. But for my patients, I could speak to as my patients, I find that their last treatment is usually their hardest.
Yes.
That they'll come in and they'll be sad. And it's not because they're sad that, they're completed their therapy, but they're scared. They're scared of what's to come. They're scared now that they're not on active treatment. Is their disease going to come back? They're seeing us a lot less, so they're not feeling as protected. Mm-hmm. So I often see that they'll come in and they'll be really scared and sad in their last visit. And we need to let them know that it's okay, that, their journey doesn't end here. They're still going to come back to see us in follow-up, that we're still going to make sure that they're connected to us, and that we're, paying close attention, that their disease won't come back, and that we're here if they need us. Because I think they've been so supported throughout their journey, seeing us every few weeks, or if they have a problem, they can just pop in. So I also feel like sometimes, and Dr. James, you could probably feel this too, that if the patients don't have that support at home, we've sort of been their support throughout their treatments. So then it becomes harder for them. And, you know, I was not so much because I had Maria and she was like my supporter throughout, and like I got to see her every day, so I was good. But for the patients, I can see how they're sad on their last few treatments.
You know, on that note, I'm going to take advantage of the last minute and a half of this program to say, yes, my patients, Colleen's patients, our patients often frown when we say, we'll see you in 3 months instead of 3 weeks or 4 months. And they when they come back for that follow-up visit, they often go over their time allotted because they don't want to let go, because that's the place where they are allowed to say the words breast cancer or I'm afraid or all of the cues. And I just have to give a shout out to everyone that's listening that with great pride, we are springboarding to a survivorship clinic. Maybe we'll find a different name for it. But for our patients that are not being seen often by the medical providers, as we see new patients that come in, there will be a formal facility with incredible people, with an energy and an understanding that will be there for our patients that are long-term. And I will say that I am modeling this over the survivorship clinic at Sloan-Kettering, which I was always a fan of. I think my patients were the first ones years ago that entered the program. So we'll have that up in the Capital District, probably moving forward within the next 4 to 5 months with ancillary services and abilities to have programs like this once a week. And just stay tuned, everyone. I can't thank you all enough. Please, go ahead. Colleen, thank you. I know you were seeing patients all day today while I was on administrative calls. Patients love you. Monique, I'm so glad that I've gotten to know you. You know that I'm going to reach out to you multiple times. Thank you for being part of this. Stacy,
I love
I
you.
will say it again. I will say it again on behalf of me and every patient that goes away learning something new from these programs. It's because of you and your support. Thank you, thank you, thank you, thank you. I love you. Bridget, what can I say? You know that I've been a fan for years. Maybe on the next session, and in our survivorship clinic, we'll stock the books. Give us the name of the book quickly.
Inspired Vagina, Capable Penis.
There you go. Look it up on Amazon. Okay. I've got 6 copies, 1 in each room. And Arsyl, I think we're going to keep moving forward with this. So let's stay passionate. Let's stay empowered. And good night, everyone. These programs will be available on our NYOH YouTube. You can catch up with last month's program. This one, if you're not around tonight or family members want to see it later on, next month we'll be talking about the breast. So good night, everyone.
Good night.